Hi, I'm Annalisa Nash, one of the nurse practitioners here at the Center for Colorectal and Pelvic Reconstruction at Nationwide Children's Hospital. I'm here with Dr. Richard Wood. We are here to discuss children with a diagnosis of anorectal malformation and how to know if your child has had previous surgery. Do they need assessed, or do they potentially need a redo surgery? So, Richard, when you get an inquiry from a patient or a family, what are the things that you need to know or want to know or are looking for when they're asking you questions or have these concerns that their child may need to be assessed or may need a future surgery?
Yeah, Annalisa, I think, from a perspective of needing reoperative surgery, I think it's important for us to realize that the majority of kids who have an anorectal malformation repair probably have a really good operation. But there are some that we feel we can improve the patient's functional outcome by doing redos, and we have found that in the work we've done, where if we do redo surgery, we have actually been able to improve patients' outcomes. And the areas which we often find problematic are sometimes patients have a stricture or narrowing at the area where the bowel is joined to the skin. And that usually presents with kids really straining to pass stool, or parents may sometimes describe that the stool comes out as if it came out of a toothpaste tube, something like that, and every bowel movement being traumatic. I think those are often signs of a stricture. Often, though, it doesn't present like that. It can present with a lot of liquid stool and very bad rashes, and that can also be a sign that they have a stricture. In addition, we do see children who have a significant prolapse, and sometimes that requires further surgery. And I would say the last group would be kids where maybe the anus wasn't located accurately, and that may be the child who's gotten to potty training age and really has no sign that they have any sensation. Now, it's true to say that some kids with anorectal malformations don't have sensation because they have a very complex malformation, but most or many children will have some level of sensation, and if there's absolutely none, that may be an indication that the anus wasn't located correctly and may need to be assessed in a sort of collaborative way like we do here at the Children's Hospital.
Great. So a lot of the patients that do come to us have had a previous colostomy for their surgery, for their primary surgery, and so that is a major concern from a lot of our families is if my child does need surgery again, are they going to need a colostomy again?
Yeah, and I think that's a really good question because we know colostomies come with a lot of morbidity. They do serve a role, but they do have a lot of issues, and we haven't found it necessary to do colostomies here. We've done over 150 redos here, and we've only had to do one colostomy in that time. And so I don't feel that it's something we need to do. We are able to safely manage these kids without colostomies when we do their redos. I think, though, we do have to be very meticulous with the way we look after them post-operatively. So we often ask families to stay at the hospital for a week or so post-operatively so we can really watch the wound very closely and make sure it's healing well. So we don't demand them to have a colostomy, but we do really want to get very close contact with them post-operatively to make sure that things are healing well, because obviously, they're going to be stooling through their surgical repair site, and so it's something we need to watch. In addition, we don't find it necessary to keep kids NPO after surgery. That was something that was done previously, but we've studied it and realized that that's not necessary, and so children are able to take clear fluids for the week that they're having their wounds closely watched. And that has made children and families a lot happier because they're not completely NPO. Although I know the clears do get a bit boring, most families manage it reasonably well.
Okay. And then do you want to speak a little bit to dilations, whether or not that children need dilations, but after they've had that redo surgery, because that's been a lot of families, that's been a pretty traumatic experience that they had to deal with prior.
Yeah, so dilations are a huge area where families have concerns. When we studied what causes stress about having a child with anorectal malformation here, we found that dilations is the number one stress causer in kids with ARMs. And so we've done a number of things to try and ameliorate that. We don't do dilations on kids who get redos because we feel that it's not necessary. Sometimes the skin does narrow a little bit after the repair, but we generally at about 3 months will reassess things, and if it has gotten a little narrow, we're able to do a very small day case operation to widen the anus again, and we found that to be almost universally successful. In addition, we have also tried to study whether dilations are necessary in the primary cases, and that's something which we'll hopefully learn more about in the future. But we definitely wouldn't advocate dilations in older children because I think they cause a lot of stress both for the children and their families, and probably aren't necessary or helpful.
Right. One of the other major questions that we get asked a lot is, how will I know if my child's going to be continent in the future, and how will I know if they're going to need constipation management for life, or do they just need it right now? And a lot of times this is the discussion I'm having with families on a regular basis. You know, it's very challenging to put a child in a mold and say, because of this, you're definitely going to need constipation management, or you're definitely not going to be continent. But we are able to discern somewhat with the type of malformation, the spine and the sacrum, you know, kind of guess what their potential for continence is. But it's the kids that fall in the middle that we're a little unsure of. So we are going to, you know, put those kids through bowel management, and we're going to get them to a place where they're at least socially continent at their specific age. And then we will try to get them onto an oral regimen that will then keep them socially continent and free from constipation. But we also get a lot of concerns with lifetime Senna use. We actually did a study here and found that there is no long-term effects of Senna, no adverse long-term effects from it, and it's a very safe medication to take long-term. We do find that constipation management in kids with anorectal malformation is very important, because continence and constipation are two totally different things, but they are intertwined, because if a child is constipated over time, their rectum can stretch and stretch, which is how that child feels when they need to stool, is by the stretching of the rectum. So if it's been stretched out over time from chronic constipation, they're going to lose that sensation. And so we really want to stay on top of constipation management. So it's not something that we're going to say, you know, just stop taking it and see what happens. We're going to really want to be involved in that process in the long term. And it's hard to say in 20 years, is your child going to need a laxative or not? You know, time will tell, but we are going to help you guide that process, and we'll help you know when do they need less or when do they need more.
I think you raise a very good point about the sensation. I think that group in the middle that we're learning about, I think a lot of the ones where we learn they're going to be able to potty train are the ones where they have sensation. And I think you raise a point very well that we have to be aggressive in treating their constipation, because that sets them up for success to be able to feel. And when we get feedback when they come to clinic and they start telling us they're getting feedback that their kids can feel, those would be the kids that we would suggest do potty training or bowel management week with laxatives, because that's usually the sign that they're likely to be successful.
Right. And then one last question. Why is it so important for a family and a child with anorectal malformation to make the journey to Columbus, Ohio, of all places, to be a part of a collaborative center? What do you think is most important about that?
So, you know, I think the surgery is a part of the care of anorectal malformations. I think if you don't have a good surgery, you're probably going to find it really difficult to have a good outcome. But it's equally true to say that if you don't have good postoperative care, even if you had a really good surgery, you're not going to get a great postoperative outcome. So I think one aspect would be what we've been talking about, the bowel management care, making sure we aggressively treat constipation, making sure we help and partner with families to help them to potty train their kids where possible, and where not possible, have them socially clean for school. Because we often talk about the continence clinic, but I always talk about the confidence clinic, because really it's about children confidently going to school and being able to integrate with their peers. So I think the bowel management is one aspect of that, and I think it's hard to do bowel management well without a team. And then I think the second component to that is the multidisciplinary care. So, our young girls who have anorectal malformations have gynecological issues both when they're small and as they get older. I think all of our patients, boys and girls, have urological components to their care. And we want to be really mindful and careful that we're looking after their kidneys well, that we're looking after their bladders well, and that we are being preemptive with regard to their care rather than reactionary and kind of trying to put the horse back in the barn afterwards. And then I think also being very careful with how you do the follow-up alerts you to other things, like if suddenly their bladders are no longer working as they were, perhaps we need to think about, have they got a problem with a tethered cord, or what else is going on? And so I think when you have a collaborative center and you have all the people putting their eyes on a patient and caring for the patient, I think we definitely do see that patients get better outcomes. So it's not to say that local providers can't care for patients. We would like to partner with local teams as much as possible. We don't want to remove patients from their local care source, but we definitely want to add value with multidisciplinary and complex care where it's required for patients.
Great. Well, I'm Annalisa Nash, one of the nurse practitioners here at the center. This is Dr. Richard Wood. If you have any questions and would like to contact our center, please reach out to us at 614-722-4086 or at ccpr@nationwidechildrens.org. Thank you.
Thank you very much.